Well, I think we have three excellent speakers earlier covering various aspects of the tumor ablation and including the good technique in surgery. And each one of us has our way and means and our trick to achieve the best local tumor control. I will be sharing on the use of alcohol in enhancing or tumor ablation, especially those in large tumor or those Juxta vascular or those so-called high-risk category. This is my hospital. We have three sister hospitals. I'm in the main hospital, Swangjaya Medical Center, which is 37 years old. And ever since we acquired this Angel CT system, most of our procedures are guided with 2 or 3 modalities in achieving the best clinical outcome. Indeed, yes, a significant impact on our cases in terms of the survival and the local recurrent rate. Especially with the TASE, we have developed new protocol and advancement in getting the thing done. And we have actually breached beyond many levels where a lot of time, when it's not possible, we could get it done. The content of my sharing would be on tumor ablation, current position in oncology practice. The previous speaker has shown some data and papers on what's current status. I will share some latest papers just released, and a bit more on incomplete ablation, why and the reason, how to achieve a larger ablation, and last we were talking about the combining ethanol or pure alcohol in achieving a better clinical outcome. As an IR, I think we have this advantage of combining various technologies, and essentially we have 2 categories. There's local ablative therapy and the transarterial interventions. In the local ablative therapy, the use of the RFA was actually way back in 1983 when I was in the Hemisphere Hospital, London in 1997. The biggest ablative tumor we could consider was 2 centimeters. Anything bigger than 2 cm were deemed not ablatable. That was the old technology of RF ablation. And of course, currently, things have changed and we could actually ablate as big as what we want. It's just the sky will limit, and the complication rate as well as the recurrent rate which we are looking at. And essentially, most of us, we enjoy an excellent success rate of about 95%. The best available option is very much institutional specific, which is very subjective, depends on the availability of technology, as well as the IR's technical competency and training, the equipment support, the availability of consumable, your clinician who are they going to sharing the case with you, or are they going to keep the case to themselves? And in places where there is no national health scheme, financial capability is also an important factor to consider. Regulatory control is another one which could be quite prohibitive. Essentially, in the thermal ablation, we have 2 categories, which is resistive heating, which is RFA, and dielectric heating, which is microwave ablation. And there were quite a few papers published pertaining to comparing between the RFA and the surgery, which has a better outcome, and we have significant evidence to say that there is no statistical significant difference between the survival rate for both modality. And this is the latest in the published which is published recently in 2019. Namiki Izumi reported the Japanese result of 3-year recurrent-free survival, which is equivalent between surgical arm of 49.8% and RFA arm of 47%. There was no survival, no difference in terms of survival benefit. And again, is on those lesions less than 3 cm. And this is this year, 2021, Masatoshi kudos. Follow up with their second update on 5 years objective survival of the same paper. Again, surgical arm and RFA arm has most equal survival outcome with p-value of 0.828. And the conclusion is that objective survival and recurrent-free survival were not significantly different between this group of patients. Again, less than 3 cm and 3 nodules. This is essentially following the BCLC staging guideline, where ablation is being used as one of the curative modality. But in the clinical front, a lot of us do cases far beyond the 3 cm limit, and especially intermediate stage. And we know that under this intermediate stage CC, the EASR and your RTC recommendation that they actually allow us to do up to 5 cm. But I'm sure a lot of these IRs around the world are doing cases bigger than that. When you are doing a bigger case, you have a challenge of how to achieve a best clinical outcome. And in this kudos kinky criteria modification from modified probability subclassification of BCLC B cases. Under B1 category, ablation is one of the recommended techniques in achieving curative intent. And we need to understand as an IR, if we want to survive in this industry, it has to do equally well like the surgeon. And hepatic resection is not recommended in the treatment of HCC when the expected operating mortality rate is more than 3%. In these cases, they refer for ablation. And as an IR, we have to look at the local recurrent rate of HCC for our FA. Should not be more than 9% in order to stay competitive. So essentially, your cutoff point of recurrent is 9% in the as a primary treatment for HCC. And hence, in this particular instance, the primary goal of ablation is to achieve a complete tumor coagulation with an appropriate safety surgical margin of about 10 mm surrounding the lesion. And in this aspect, incomplete thermal ablation is very, very common, and the rate increases with tumor diameter, and especially those HB aggressive type, where the satellite nodule could stretch more than 10 mm from the tumor margin. And the maximum volume of induced ablation has significantly improved by the today's standard using the multiple probe RF technology or microwave ablation. Again, it's very much technically demanding, and not everybody is able to achieve a good result. Hence, the local recurrent rate could be as high as 60%. The essentials in this situation is to acquire a sufficient 3D safety margin, which is a critical factor before we are able to recommend this technique as a primary treatment for HCC and even for metastasis. RFA or microwave local recurrent rate can be lower than 5% when you keep the minimum safety margin to 10 mm. We are complete 3D safety margin. So the technical improvisation in this case is you must be able to control heat sink effect in high-risk cases as well as to achieve a complete homogeneous ablation. Not to forget, both liver metastasis and HCC are considered global liver disease. What you see, one lesion could have multiple minute one, which is a flare and appear, and we know 50% of the patients will have new tumor coming out in next 3 to 6 months, despite your complete ablation. To achieve a good ablation margin, this is HPE result, gross tissue pathological result, which showed area of complete necrosis, complete necrotic zone. And this is the hyperemic area. In this hyperemic area, if there's any satellite nodule which are not covered, this will be where the current be. And in order to achieve a good ablation and complete ablations of the tumor up to the wall of the vessel, this is where we are concentrating on the heat sink effect and how to achieve this. This patient was achieved with combined RF and the alcohol ablation. And as a tumor getting bigger, you may be able to completely ablate the center. The marginal recurrence always become a nightmare, and these are not easily controlled. Come to the incomplete ablations. There are many factors which are affecting the clinical outcome. Essentially, is the irregular shape of coagulation and necrosis, which could be due to Heatsink effect by the vessel, your needle geometry, needle tip location, tumor heterogeneity, and uneven energy distribution. And as an IR or the user using this technology, we have to know very clearly that what we are ablating with one single 3 cm RF needle, what is the maximum in vivo diameter we can achieve. And the maximum in vivo diameter is 2.45 cm, not the 3 cm. So if you have a 3 cm nodule, you really need to do 3 or 4 overlapping ablation to achieve the result. And for the juniors, you have to really realize that the IFU or literatures given to you by the company are all ex vivo sample, where the ablation zone is always bigger than what we achieve clinically. And look at the microwave ablation using 2.45 gigahertz again, right? Between 41 and 80 watt. The maximum diameter achievable in the liver is at 10 minutes is 2.73 cm and 3.2 cm for both power. So bearing in mind that if you have a 4 cm nodule, then if you are using 80 watt, you may not be able to complete the work with one position. And we know that between the microwave, there are 2 frequencies which are commercially available, 2.45 gigahertz and 915 megahertz. 915 megahertz is just like 5G technology, the longer wavelength. We have better penetration and coverage, and you can see that between 915 and 2.4 gigahertz, the ablation diameter is always bigger in the lower frequency. And in this instance, 915 megahertz at 80 watt is 3.84 cm diameter, comparing to 2.37 cm diameter. And unfortunately, most commercially available system is 2.45 gigahertz system. And that's very critical for us to know how well and how good the performance of the needle in our clinical work. And you compare the two again between 50 and 80 watt of 2 different frequencies. You can see that at 50 watt, the maximum diameter achievable is 3 cm at a temperature of 62 degrees. Okay, for the 915 megahertz, whereas at 1.5 cm is only 38 degrees, which means that your ablation margin is really just 1 cm from the needle with the higher frequency system. And if you increase the power, you can achieve a bigger diameter. That's why we always ablate longer and a higher power using a microwave or RFA if you want a bigger diameter. But RFA will be limited by the geometry, whereas microwave can grow bigger as what we expected. The other thing is a heatsink effect. If an operator or IR can handle heatsink effect, you can always achieve a very good clinical result. What we are seeing in the current, a lot of literature or perhaps a lot of the product catalog, ex vivo healthy bovine liver always show you very nice round spherical ablation, which is not true in the clinical front. We can see all kinds of shape and distortions. And the shape actually could be quite unpredictable, and so-called round predictable spherical ablation in this particular product is only achievable in the ex vivo healthy bovine liver. Heatsink effect is a major concern. A lot of time we see our tumors are straddled in between various vessels, hepatic vein, hepatic artery, portal veins, etc. And this would result in marked local recurrence. And how are we going to achieve a complete ablation until the vessel margin is where we're going to discuss today. The last bit on the incomplete ablation is, of course, the challenge because of the rapid and fast ablation. You can see that if you ablate slowly at 45 degrees, the tumor will die at 20 seconds, and if you achieve 50 degrees, within 2 seconds, the tumor is already dead, and if it's 100 degrees, it's instantaneous and tumor tissue evaporation. So in this instance, if you ablate too fast, you have this local charring effect, and hence causes secondary insulation and prevent growing of your ablation zone. We would encourage to use slow metallurgical energy deposition to grow the area ablation. This is an example of a Starship needle, where you go slowly, you can have a very nice spherical target area of necrosis, whereas if you push it very, very hard and go straight on a high power, this is the flower shape and small lesion you are able to achieve. And we always recommend slow ablation, step up slowly to achieve a homogeneous large areas of coverage. Bigger burn, there are many ways we can achieve bigger burn. I'm sure all know what they are doing. Okay, of course, overlapping burns, 3 to 6 position, or cluster needle, or multi-type Starship electrode like Lavin, Rita, multipolar RFA, perfusion electrode, combined case ablation, or you do hepatic veins or the hepatic artery occlusion to get a better result, like in this case before, followed by RFA, then we can achieve a complete ablation with good 3D safety margin. Microwave is essentially coming very strongly, and those days we used to struggle using RFA, but most of us have switched to microwave, and of course multi-antenna microwave can offer a better result. Today's discussion is very much concentrating on the optimizing the ablation using the RFA. This was what I have used since 2003 in optimizing my clinical outcome. In the thermal ablation, we have 2 categories. One is dry field, like lung or bone, or wet field, where we use endogenous fluid or an externally applied low conductivity irrigants, like the lung, where you infuse some normal saline to improve the conduction and produce gaseous irrigants to kill the tumor. When we add in alcohol is a very powerful cellular coagulating agent, and it induces non-selective protein degradation and cellular dehydration instantaneously, and hence result in local area of coagulative necrosis within and around the tumor. Addition of pure alcohol during thermal ablation offer a wet field environment and a gaseous irrigant, and the boiling point for alcohol is 78.32 degrees, hence it often excellent sclerosis of tumor blood circulation and cellular hydration, in addition to its gaseous expansion into the tumor tissue, sometimes not achievable with your energy distribution. How do I do it? Usually I do slow injection using a parallel Chiba needle, amount not too big, too much, 2 to 5 ml slowly over the ablation cycle, and with this you can achieve 30% additional ablation zones. And it's good for both hypervascular and avascular lesions. In the avascular lesion, it's advisable for you to start injecting alcohol after 2 or 3 minutes of ablation when the cells are more kind of like denatured, and you allow the permeation of alcohol better. And sclerosing and boiling effect of the alcohol enhance ablation of irregular peripheral marginal residual and abolish Heatsink effect. It has better coverage in overlapping offer better coverage in overlapping consecutive ablation. And one thing you have to be very careful is if you do alcohol injection, you must watch very carefully using real-time ultrasound for the intravasation to the vessel or bile ducts. This is a patient earlier with the centrally located tumor from a colorectal metastasis, which is extremely FDG avid. So we have single ablation using the Q-tip needle and parallel needle to inject the alcohol. We are able to achieve a diameter of 3.54 cm as compared with 2.54 in the normal instance. And notice that it's about things on IVC and the right haptic range, which are able to achieve a better clinical control, like in this case. Another patient with giant HCC combining the two, you will be able to achieve a far better and more correlative homogeneous ablation if you add in alcohol in your protocol. Another patient, we are able to ablate up to 8 cm, and post-ablation show complete ablation at 1 month. Sometimes there are many lesions which are 3 or 4 cm, and with the current technology using microwave, we can actually take care of this quite at ease. But if you are using RFA, it becomes a great challenge. So we add in some alcohol in your ablation, so you achieve far better control. This is 6 months, so that the tumors are all ablated. How about this patient, 77-year-old CA colon single liver metastasis? The tumor is 4.5 cm. Not keen for liver resections, and we decided to do the RFA using the 3-probe E series and eternal. We 5 mils eternal infusions and ablation over 16 minutes using automatic impedance control at 130 to 175 watt. We were able to achieve a nice ablation zone of 5 by 5.2 cm. Notice that we don't want to grow this too big because your local damage will be too extensive. And this is 1 month. It showed that very nice coagulations, especially the portion which is touching the right haptic vein, and that is actually adequately taken care of by the alcohol. And this is a 6 month. PET-CT 6 month, 15 month MRI, and 14 months ultrasound lever. She's still in clinical remission and is not on any chemotherapy. And last case I would like to share with you is this 70 years old patient, happy post right lobe resection, the liver with recurrent HCC74A. 6 weeks earlier, the tumor was 3 by 3 cm, but because of the COVID pandemic, the government hospital stopped seeing all these patients, and finally she came to us 6 weeks later, and the tumor has grown to 4.8 cm. We offered TAC, but she's not keen, so we decided to do alcohol-enhanced microwave ablation, and on the cardiac Doppler you can see extreme hypervascularity of the tumor with multiple adjacent vessels. So with 2 needles, one is a echo microwave antenna and 1 Chiba needle, and we infuse alcohol, 4 mils alcohol slowly over the 5-minute cycle, and then we ablate at 60 watt for 3 minutes, 100 watt for 2 minutes. This is immediate post-ablation of 6 by 6 cm diameter, which is more than enough to cover the area of interest. The patient will be back probably next month for the follow-up MRI to assess the progression. We are quite certain we are taking care of the tumor adequately. So in summary, alcohol-enhanced thermal ablation offer the advantage of enlarging the ablation volume by about 30%. It optimizes juxta vascular coagulation and decrease heatsink effect, avoiding or minimizing thermal injury to adjacent critical structure like major vessel or bowel. So in the sense that you reduce your ablation time and ablation cycle. It also minimizes the residual marginal tumor or incomplete ablation, and it definitely offer a more effective overlapping burn. Not many papers describe the use of alcohol in the tumor ablation, and in this paper AJR 2004 from Shankar, it showed that you use RFA and RFA plus alcohol alone, it was able to increase the mean ablated volume by almost 2.5 times. And this paper from Taiwan, concentrating on the use of alcohol with RFA in high-risk patients, which means that juxta vascular or those extremely hypervascular tumor, they were able to modulate the cases to optimize the clinical control with the local tumor progression-free survival rate equivalent to those low-risk RFA cases. And another patient, another paper from China on radiofrequency combined alcohol ablation with HCC, a systemic review from 13 trials of 1,621 cases. They reported that combined RFA and PI was associated with a significant improvement in objective survival rate at 1.52 and 3 year and significant reduction in local recurrent rate. So the conclusion is combined RFA and PI, or perhaps in current practice, combined MWA and PI, we significantly improve the objective survival and reduce the risk of local recurrence. One thing to note is that alcohol could be a very dangerous item if you don't use it correctly, and never use it in the lung or around the nerve or the high risk of intravascular intravasation. Excessive alcohol injection would pose a risk of biliary sclerosis and stricture if you intravasate into the bile duct, non-target area infarction or acute pulmonary hypertension. And if you burn too big, myeloma could be quite a difficult issue to control, especially those juxta biliary locations. With that, I thank you for your attention.